Thank you very much. And it's absolutely wonderful to be here. It's a real honour to be here, actually, to have an organisation that dedicates a day to menopause. You're ahead of so many other companies and organisations, and so you should congratulate yourself about this, because it's a really big issue for our society, as we've neglected menopause for forever, really. And to quote Louise, it affects 51% of the population directly and 49% indirectly. It's all of our issue. Very important. And actually, thank you for those speakers, Zoe and Lorraine. I haven't heard such an articulate pair of people talk so well about the menopause. They've said it all, really. I think my job's done. They've expressed how many myths there were about their own conditions, quite two different situations, and how if they had been empowered with knowledge at the beginning, the trajectory would have been quite different, I'm sure. So much to learn. So we're going to be talking about managing the perimenopause and menopause. Just a little bit about me. I'm Rebecca Lewis. I'm a GP and menopause specialist and co-founder with Louise Newson of the Newson Health Clinic. So I'm a director there, a director of the Balance app and of the not-for-profit research and education company, and I have no financial declarations. I don't work with pharma. Just a language really thing to say. For the purpose of this talk, we refer to the menopause affecting women, and we do acknowledge a broader group of people who may identify as transgender, gender fluid, agender, or non-binary, who may also experience the menopause. So important to be aware of that. Thank you. So the scale of the problem. Well, 47 million women will reach menopause year on year globally. 25% will suffer severe menopause symptoms. 25% will have mild symptoms. So 75% of us will be having quite moderate to severe symptoms. And we cannot judge the severity of symptoms based on our own experience. It will be very different, so we cannot judge others by our own experience, our mother's experience, a sister's experience, etc. But this is important. 77% of women did not realise their symptoms are due to the menopause. As Lorraine pointed out, I thought that was an excellent slide of what she did know, and basically what people do know. It's hot flushes, your period's going a bit funny, and maybe you don't sleep very well, generally. If only it was that, we wouldn't be having conferences and talks like this. It's so much more, and this is the work that Louise has been doing tirelessly, and we work alongside to support, to really empower women with knowledge. 79% had visited their GP. This is a survey we did on 3,000 women. 79% had visited their GP and about their symptoms, and 7% had had to visit more than 10 times before they got adequate advice. And 44% had to wait for a year, and 12% had to wait more than 5 years before they got the answer. It's outrageous, really. There is an evidence-based treatment for menopause. We know how safe it is and how beneficial it is. This is HRT. As a GP, it is one of the most rewarding specialities to be involved with. It can really help transform women's lives once they get the right dose and the right type and combination of HRT for them. Not the same as their friends, but for them. And it's not the doctor's fault, really. It's society's fault. We haven't discussed menopause. It's been a Cinderella subject in medicine for many years. I was hardly taught about menopause at medical school, neither was Louise. So this is the generation, and still that's the same to this day. So you can be an excellent doctor in many specialities, but menopause won't be on your radar because it hasn't been discussed or talked about. Or sometimes it might be on your radar, but you may be as misinformed as women in general or men in general because it hasn't been addressed medically properly. Thanks to Louise, enormous thanks to Louise, what she's doing, she's changing that. So what goes on? This is a bit of a Mickey Mouse slide, I'm afraid, but I think it's quite useful. It serves a purpose of showing what's going on. I like to drill down to what's going on in our bodies, the physiology. So you can see The estradiol is in the red and the progesterone hormone is in blue. And you can see how the estradiol level fluctuates up, and there's a little bit of a fluctuation that we all kind of know about in a girl's teenage time, or pubertal, pre-pubertal. We're aware of mood changes, and anyone with daughters, we remember that in ourselves as well. It can be a bit tricky that time. But then things start to settle down for most women as they have regular monthly cycles, and their estrogen levels will fluctuate through that cycle, and that can still be a problem for some women, but much more stable, you can see there. And then we come to this rather chaotic time of the perimenopause, which it ambushes us really, because first of all, perimenopause on average will start in a woman's 40s. The average age of menopause is 51, is when the periods stop. And the perimenopause is the time where our ovaries are still working a bit, but not properly. So they're beginning to decline. And that can precede the final period by 10 years. So on average, every woman in their 40s will either be perimenopausal, and coming up to their final period at age 51 on average, or they will be postmenopausal, like Zoe, they've had an early menopause because they've had an operation to remove their ovaries, or they've had a natural early perimenopause, or they've had treatment for chemotherapy, etc., medical treatments. So it affects all ages, important to remember. But the perimenopause, women are still having their periods. It may have changed a little bit, got a bit longer, further apart, closer together, heavier, lighter. And these fluctuating estrogen symptoms are beginning to cause symptoms, particularly just before the period in the early days. So poor sleep, muscle aches and pains, increased anxiety, vaginal problems, bladder problems, flushes and sweats. 80% of people may have flushes and sweats. 20% will never have a flush or a sweat. So we can't rely on that as a signal, hang on, I'm there. It might never happen. And you can see the graph looks chaotic, and you can see why women don't really understand what's going on, because they may have a period of tranquility again. You can see the line flattens off for a few months, and then they put their symptoms down, the job, caring for elderly relatives, teenage children, a lot on our plate. It must have been that, because I feel okay now. But then it happens again and again. It's only when they look back in time that they can realise this. I didn't realise I was perimenopausal either for some time, because it ambushes you and it creeps up. So that's what's going on. And this is how it can make women feel. And these quotes are sad. I feel like a shadow of my former self. Where have I gone? I feel low and flat most of the time. My zest for life has gone. I've never felt this low before. I feel diminished as a person. That's particularly moving, I think. I'm just existing, and I feel like a zombie. I mean, it's awful that 51% of the population, many women, will be feeling like this. How long can menopausal symptoms last? Well, the 5 years, it's a myth again. They did do a study which showed on average symptoms lasted about 7 years, but they were mainly probably looking at flushes and sweats. And quite often they do abate in time. However, I've got 90-year-olds in my general practice who are still having flushes and sweats. So symptoms can go on for decades for some. Or they may diminish because in previous generations, like my mother says, I never had any problems. She had plenty of problems. But what happens is people can adapt. So they may have given up work or gone part-time, have an afternoon nap, stop driving on the motorway. Their other half does that because the anxiety is too much, perhaps stop flying, going abroad, and it was accepted because all their friends were doing the same as well. No, I haven't got any symptoms, sorry. So they may settle for some, but the hormone level from that graph you saw was very low level post-menopause. That's never going to come up again. And as Louise says, once you're menopausal for life. You may have symptoms that improve, but the low hormone level is with you forever, which is normal and natural. And Louise has already discussed this, but I think it's worth saying again. with low hormone levels, it puts us into an inflammatory state. We know that 17-beta estradiol, this is the good type of estrogen that our ovaries produce, is a natural anti-inflammatory, and testosterone as well. And without this hormone, we see a rapid aging process in women with bone loss or osteoporosis, thinning bone, heart disease, heart disease increases 5-fold after menopause. 1 in 2 women will suffer with osteoporosis over the age of 50. They won't know they have it because it's not painful. It's not the same as osteoarthritis, which is painful. Type 2 diabetes goes up. Obesity, to try, especially around the midline. Cognitive decline and dementia. Depression. All these symptoms, diseases increase when we've lost our hormones. In the workplace, we did a survey of 3,000 women. 18% of people had to take 8 weeks off work due to their symptoms. You know, that's an enormous cost to the individual and their organisation. 21% did not go for promotion due to their menopausal symptoms. 18% had to reduce their hours. 12% resigned. Can you just consider that, the effect, the financial effect on families, the financial effect on the organisation they're working for, the loss of a highly skilled worker, the retraining, the sort of, all that sort of area costs the employer an enormous amount, the sick pay. The cost to the nation. If someone's not working, they're not contributing to the pension pot, they're not contributing to GDP. 79% said if they had more support at work, this would have helped them stay in work. So days like this are really important. Hearing people's experiences, like Zoe and Lorraine's, I think is really helpful. And millions of women are being incorrectly diagnosed with their low hormone levels because people haven't been taught about it. So fibromyalgia, depression, recurrent migraine, urine problems, interstitial cystitis, bladder, all these symptoms are often, not always, but often compounded or maybe entirely due to low hormones. So we should think of this as an opportunity. Here we are, approaching menopause, or it's going to come. Let's get ourselves informed about it. What does it look like? It'll be different for different people. There'll be some strange symptoms people can have and classical symptoms. What can we do about it? How can we manage it so that we can carry on being our best selves for as long as we wish to be, carrying on at work, enjoying life, because we don't have to suffer. There are now really clear guidelines about treatments for HRT from NICE, the International Menopause Society, the European Menopause Societies, saying how safe HRT is and how this is the treatment. Of course it is. It's replacing the hormone that has been lost. Much like if people have thyroid, there'll be people here who have low thyroid. We give them thyroxine to replace it back to normal levels. And that's all HRT is doing. It's not giving them super high levels, it's replacing those low levels from that graph we saw back to the normal physiological range before the menopause. And the summary of the guidelines, it's about individualized care. So there's not one size fits all. Young women, this is really important, must really have hormones at least till 51, and I would argue for longer than that, because all those health risks we just listed are much increased if the woman is younger, if they've been without hormones for longer. So very important they have hormones at the right level, at the right dose for them, and maybe have to have higher doses because they're younger. The benefits, this is NICE guidance. For the majority of women, the benefits of HRT outweigh any risks. There's no maximum length of time of taking HRT. So this 5-year time taking, then you've got to stop is nonsense. Let's just talk about these hormones. So estrogen, we use now, really, I think everyone, first-line treatment should be a body identical, and body identical just means it's exactly the same structure as the estrogen we produce from our ovary. So the replacement is exactly the same. So physiologically, it's sort of perfect. It's replacing like with like, because there are different types of estrogens. In the old-fashioned HRT tablet estrogen, some of them, they don't really use this type anymore, was from pregnant mare's urine. And it wasn't that good. It was alien, it was foreign to our bodies. So it did help a bit, but this is so much more effective with much less side effects because it's exactly the same estrogen as we've been used to. And we give this through the skin because it's even better to do that. It's safer because it doesn't go through the liver. When you take a tablet of estrogen that goes through the liver, it increases the clotting factors a little bit, so it increases your risk of blood clot, a small amount, not very much. So some people have risks of blood clot, they can't have oral estrogen, or it's advisable not to. But this gets around that very nicely. So people with conditions or on other sort of medications that could interact with the liver metabolism with estrogen, through the skin, there's no such interaction. It's very natural and normal. So very good. I would argue that every woman should have this anyway. And I think generally HRT is given through the skin as a spray or patches. They're different brands, different types, different brands of gel. And that's the best way. Progesterone's needed it for women who have a womb, because estrogen could cause thickening of the lining of the womb, which isn't very healthy if left for years and years. So progesterone keeps that lining thin. And again, this is body identical progesterone we have, and the old-fashioned progestogens, they're called, were synthetic and very different and caused a lot of side effects. So this is our natural progesterone, the same as the ovary produces, and it's from the yam root vegetable again. Like the estrogen, is it? They're both derived from the yam root vegetable, so a nice derivation source. So much less side effects. Testosterone, this is the interesting hormone that's gaining sort of quite a lot of interest. As Louise said, it's a female hormone. We have exactly the same hormone as men, but at 10% the level of they do, and men have 10% the level of estrogen as we do. We produce much more testosterone than estrogen, and as Louise said, it begins to decline in our late 20s, early 30s, just gradually decline. The main source of testosterone is from the ovaries and the adrenals and the fat cells. So when we lose the function of the adrenals, it will decline ever more. Now, testosterone has been looked at and has been used for decades with very good results. It used to be an implant form. But they haven't really looked at it in a scientific data, clinical scenario. They've looked at it in one way, for looking at libido, and yes, it does improve libido, very much so. There are smaller studies that have shown how much it helps mood, concentration, memory, stamina, strength. And we find that as well clinically with our experience of seeing 4,000 women collectively in our clinic a month. We find when we treat women for reduced libido with testosterone, and most women have reduced libido in the menopause. I've not yet met anyone who hasn't really. What happens is, the libido improves a bit, but more importantly, their mood improves, their sleep, their energy, concentration, word-finding difficulties. So it can really help some women, not every woman perhaps, but many women do find it beneficial, and so that's why we do use that. It's not licensed for the menopause, although it's approved by NICE guidance, which should be considered for women with reduced libido despite HRT. But at the moment, it's not licensed for women. It's licensed for men, but not for women. So we have to use an off-license preparation, or we use a private androfen, which is licensed for women in Australia. So they're sort of a bit ahead of us from that point of view. What are the benefits? Well, clearly it's going to improve symptoms. Of course it does. These symptoms that Lorraine put up on her slide are all symptoms of estrogen and a bit of testosterone deficiency as well. So if we replace those hormones, those symptoms improve, like replacing thyroxine, as I said earlier. So it's the best at improving symptoms. It reduces our risk, and for free, it reduces our risk of osteoporosis. It's a treatment for osteoporosis, in fact. Reduces our hip fractures and vertebral fractures. We need to be mindful that 75% of hip fractures over the age of 65 are in women. There's a 20% mortality, and if a woman does survive a hip fracture in her 70s or 80s, there's an 80% risk of dependency to a certain extent after that. Heart disease. HRT will halve the risk of heart disease if started within 10 years of a woman's last period, or under the age of 60. Reduces the risk of diabetes by 30%, reduces the risk of major depression and dementia in younger women. Certainly that's been proven. But yet, only around 16% of women take HRT in the UK. It's probably because they don't understand this. They don't realise how beneficial HRT can be. Doesn't mean to say everyone needs to be on HRT, but as we keep saying, just be aware of the benefits and the risks and then make your mind up. And you might choose not to have HRT, completely fine, but choose it for the right reasons, not based on myth. So yes, if HRT started within 10 years of a woman's last period or under the age of 60, heart disease is reduced by 50%. The commonest cause of death in women is dementia and heart disease and stroke. Breast cancer is right down there, number 7 or 8. Very important to realise that. This is osteoporosis. I'm going to just do this slide because people don't always know what osteoporosis is. They often confuse it with osteoarthritis, the painful swollen joints that often need hip replacements and knee replacements for. But this is thinning bone. And we don't know if we've got thin bone because it doesn't hurt us. It's just one day you might fall over, perhaps later on in life, and just a tiny little fall and fracture something because you've got fragile bones. And you can see on the slide on your right, is that, I don't know which way you're looking at it, on your right is osteoporosis, how thin and airy, like honeycomb, and that's lack of estrogen. And this is what we're trying, again, I just want this visual really to see, because it's such a silent disease, this is what we want to prevent. When this woman is upright on the far left, this is when we need to be thinking about prevention of getting to that stage. So important. And there are lots of things we can do to prevent that. Diabetes, we've said, it reduces the risk. Mood, again, depressive symptoms occur in 45 to 68% of people who are perimenopausal and menopausal, and HRT is very effective at treating that because there are receptors, remember that slide Louise showed, all the receptors in the limbic system, which is to do with our mood regulation, is governed by estrogen and testosterone. Mortality, so people who start within 10 years of their last period actually have a slightly lower risk of early death than others. They live a little longer than people who don't take HRT. So why are so few women taking it? Only 14% women are worried. Healthcare professionals are worried. They've been misinformed by the media. This really alludes to a big study, the WHI study, that was done in America. In 2002, the results were released to the press without being looked at properly. It was an enormous study that had cost billions of pounds. And they had applied the wrong statistics to the data. I mean, I don't know how appalling that sounds to you, but it sounds really appalling to me that actually you spent all this money on a study and they didn't do the correct data analysis. And what they showed is that it increased they thought it increased the risk of breast cancer, increased the risk of stroke. And they released that to the media, the medical media and the general media, and there were people in the study who knew better and said, please don't, we think we need to look at this properly. Hang on, we think there could be a glitch. Too late, gone. Damage had been done. I remember reading it myself, I thought, I don't think I'll bother with HRT. That sounds, not for me. And it was wrong. It was actually wrong. They've gone back 2 years later, they did the proper statistics. It didn't reach a fanfare because bad news sells. It didn't get out there. And the people in charge of menopause, the societies and the medics didn't really get it out for people, to medics or women. Don't worry, guys, it's okay. This is what happened. Louise is doing that now, thank God. But no one did anything. So we've had years and years of thinking wrongly, incorrectly. I'll come back to what it did show, that study, in a second, because there's some good results from that study. But just to say a little bit about breast cancer, Unfortunately, breast cancer is common. As a woman, we're all at risk. 1 in 7 of us are at risk of breast cancer. But thank goodness, 90% completely curable now. So that's very positive. There is a genetic tendency for some people. Genetics are genetics. We cannot change that. But there's a lot of lifestyle part that can influence our risk of getting breast cancer. Getting older, when our estrogen levels drop, paradoxically, actually increases our risk of breast cancer, much more common as we get older. It's not the disease of the young. Family history, we can't do very much about that. Obesity, we can do something about. Alcohol, we can. Reduced exercise. So being sedentary, drinking more than 14 units of alcohol a week, having a BMI of 25 or over increases our risk of many things, but as well breast cancer. But what about HRT in breast cancer? So what did they find when they applied the right statistics? There is no increased risk of breast cancer in women who are young. So people like Zoe, age 34, if you take HRT, she has no increased risk of breast cancer because we're simply replacing the hormones that should really be there until you're 51. Women, lower risk of breast cancer in women who only take estrogen. So women who've had a hysterectomy, they don't need the progesterone because there's no womb lining to thicken. Quite often, some people do take progesterone for endometriosis, as Zoe had mentioned. But if you're on estrogen-only HRT, they've studied these women for 18 years and they had no increased risk of breast cancer, in fact, a small reduction. So the progesterone, it's the estrogen and the progesterone component in this study. There was a few extra cases of women with breast cancer on estrogen and progesterone compared with women not on HRT. So there was a few extra cases. But that risk, the few extra cases, didn't actually reach statistical significance. So they could have happened by chance alone, but there were a few extra cases. But those few extra cases were less than the increased risk of drinking 2 units of alcohol every night. So the progesterone that they use, it's called a progestogen because it's a synthetic one, it's not a natural one that we use now, but the progestogen that they used back then had a small increased risk of breast cancer, very, very small, and less than drinking 2 units of alcohol every night. Now, the progesterone we're using now, the natural progesterone, we've got a 5-year study saying there's been no increased risk of breast cancer with that progesterone. And after that, we think the risk is very, very low, probably. So we need to balance that tiny potential risk even with all the benefits that we've just mentioned. So that is what, if you think the worst case scenario with the worst, most old-fashioned type of HRT, the increased risk of breast cancer is less than drinking the increased risk of 2 units. Yet you don't have a bottle of wine saying, warning, breast cancer risk. But 2 units every night would be a greater risk than taking a combined estrogen and progesterone HRT. There's no clot risk. So people who've had blood clots in the past or on medications that might increase the risk of blood clots or thickening blood or being overweight or migraines can safely take HRT as long as they use estrogen through the skin because it doesn't go through the liver and doesn't increase the risk of blood clot. And the body identical progesterone is also really important to use as well because that has been shown not to increase the risk of blood clot. That is a tablet, the body identical progesterone. And this is the problem. What happens here is that women think, no way am I going to take breast cancer, HRT, it's going to cause breast cancer. They're remembering those headlines of 2000s, yeah? So what happens is their muscles are perhaps aching because they're menopausal, it's one of the symptoms. Their motivation has gone. They're more sedentary. They can't go to the gym because they ache. They haven't got the motivation. They're exhausted. So they put on weight, and the metabolic sort of shift makes them put on weight. It's not their fault, especially around the middle. So they are there. They're sedentary. Increased risk of breast cancer. We just said exercise reduces your risk of breast cancer. Obesity comes, or being overweight increases their risk of breast cancer. So paradoxically, their increased risk of breast cancer has gone up. Perhaps if they'd been taking HRT, they would have maintained their gym membership, they had the motivation, they didn't hurt so much for their muscles, they had the motivation, the enthusiasm, the energy to do it, really, the energy to think about it. So I think that's important to think. Important to also remember the genitourinary syndrome of the menopause, a bit of a mouthful, I'm afraid, but the bladder and the vagina, really important to have good enough estrogen levels there. Without estrogen, women, the vaginal walls get thin. It's called atrophy, not a nice word, which means withering away. The vaginal walls get thin, the vulval area, the external labia, clitoral area gets thin, shrinks. The layer of lubrication, which is a healthy thing to have in the vaginal tissue, goes. So the vagina becomes dry, sore, and it related to sex and not related to sex. So women might not be having sex, but the pain can be, for some women, so much that's even sitting down, can't wear a pair of jeans because it is burning the whole time. Postmenopausal bleeding can get a little bit of a bleed from the tissues are so fragile and delicate because they've become thin. Urinary urgency. God, I've got to go now. Keys in the door with the shopping. Oh my God, quick, and a bit of a leak, or a cough and sneeze, a bit of a leak. All these sort of things. Lack of estrogen. Estrogen will strengthen the pelvic floor, regrow the vaginal tissues so they're nice and thick again and lubricated appropriately. The bladder empties properly because the coordination of the muscles is there. The sphincters are stronger. Very important. And that can be treated, again, with systemic HRT, but also local HRT. We often use both together, where the pessary of estrogen is put into the vagina, and that radiates to the bladder and the vagina. And that's very, very effective. If we don't treat this, it will only get worse with time. So we see a lot of ladies in care homes with urinary sepsis, recurrent urinary infections after urine infection. You may have relatives who've suffered with this, sadly. Had they treated their urinary vaginal tissues appropriately, that would not have happened for many, I'm sure. Some it would, but for the majority it wouldn't. So important to remember that. And this is how, when hormones are correctly balanced, these are quotes from patients in our clinic. I've got my life back, it's wonderful. My concentration has returned. My mind just feels so much clearer. I'm amazed how much more energy I have. I'm enjoying life again. I'm sleeping better, no more hot sweats. And this is one of the most common things, women tell me, I just don't feel myself. I feel a cardboard cutout. And that's so sad. But, for them just to restore their personality, their vigour, their joie de vivre, back to them, not in an abnormal way, just to their normal personality, which they've often forgotten. And there we are. So important I make no apologies for spending a lot of time on HRT because there's so many myths about it. So people, I hope, now are a little more informed about how they might need to manage it vis-a-vis HRT. There are also other important things. It's not just, they're not these lifestyle changes and HRT, they're not mutually exclusive. It almost seems you have to put your badge to, I'm a lifestyle person and no medication, or I'm an HRT person and no lifestyle. What rubbish. It's both together. HRT will work very, very effectively. It will work much better if the lifestyle's good as well. There will be a plateau on how much HRT can do if your lifestyle's not looked at. Diet, and this is for everyone in the room, menopausal or not menopausal, it's common sense. Diet, we're talking about avoiding processed foods, fruit and vegetables. We're increasingly aware of plant-based foods and getting enough varieties in our gut microbiome. The Zoe app, Professor Tim Spector's quite interesting to look for that. But having a really good diet and weight management and looking at, our obesity rate is going up enormously. Not as bad as the US, but we're getting there. So it's important to support people and help them managing weight and their nutrition. Exercise is really important. We know that for our cardiovascular health, for our bone health, weight-bearing exercise is really important now if a woman's menopausal, because that will help build muscle bulk and help stimulate bone growth as well. Vitamin D, too, very important. And having a diet that's adequate in calcium and vitamin D. There's a good online calcium calculator. If you go to University of Edinburgh calcium calculator, it will tell you all the amount of calcium in your food and diet. Stopping smoking, that's a risk factor for osteoporosis as well as cardiovascular disease and cancer. Reducing alcohol intake. Having a community like you've got today, talking about things, sharing experiences is very, very important to know how to manage your menopause properly. Mindfulness can be very helpful for the anxiety symptoms and sleep, and relaxation techniques, very, very important as well. Pelvic floor exercises for the weakened bladder and sexual health as well can help blood flow to the vagina and help some of those symptoms too. So these are things we can do without hormones, and they're very important. There are medications as well that are non-hormonal. They're not that easy in some ways. They're antidepressants, which may help some people for their anxiety to a certain extent, but they have side effects. Of course, it's not treating, restoring the estrogen levels back to normal, so it won't do anything for future health risks, but it may help some people's symptoms. There are also quite heavy-duty medications, gabapentin, pregabalin, clonidine, oxybutynin, and they have been shown to reduce flushes and night sweats by 40 to 60%, but they don't treat any of the other myriad of symptoms. CBT and hypnotherapy, I think, is very helpful for anxiety and hot flushes if you have access and can have continuing access to it. Herbs really are not regulated. We don't know much about them. We don't really know how safe they are or not, actually. There are lots of things that look natural and seem, therefore, to be safe. But as we know, we get opium from poppies, the basis for morphine and things. So I think we have to be a little bit cautious about herbs because we don't quite know how they work in the body. The workplace as well, very important to have access to treatment, and the treatment, of course, in the main is HRT. Workplace adjustments are important and respectful as well, uniform changes, fans, etc. But they won't help muscle pains, they won't help the psychological symptoms, they won't restore estrogen. But it's important to look at the whole thing, the whole person holistically. So the menopause is more than just symptoms, and it's certainly much more than flushes and sweats. I think there's one take-home message. Please don't think of menopause as just flushes and sweats. Everyone needs to be empowered with evidence-based information. Low hormone levels cannot be replaced without taking HRT. HRT is safe for most women. The new type that we're talking about, estrogen through the skin, progesterone as the body-identical progesterone. It's very important to look at diet and lifestyle. A lot of symptoms can be improved as well with that. And it's about the individual. And there are non-hormonal options as well as lifestyle changes for people. Please use the Balance app. It's free. It's access for 2,000 evidence-based pieces of information, all written by Louise. And it's really helpful. There's a community on there as well as the health report. And that's the QR code for the Balance app if you wanted it. But I just want to say thank you very much for listening, and I hope that was helpful. Very happy to have questions as well.
Just put here. I bet you learnt a lot from that. We're running a little bit close to time, so I'm just going to say is that if there's one question, get your arm up quickly. It was up. Let's just do one question, but I know that Rebecca is going to be around. We've got all the questions on Slido, so we are going to collate them and keep them, and we will get answers to all the questions back to you. So please don't think if you've asked a question, you're not going to get your answer.
Thank you. It was just about the type 2 diabetes and how the menopause can cause that, really. And then secondly, if a person is diagnosed with type 2 but not already on HRT, could that improve the symptoms and the medical condition?
So yes, how it happens is estrogen really is important in regulating our insulin production and the sensitivity of the cells to insulin. And when we lose estrogen, we get impaired glucose tolerance to a certain extent. People will get type 2 diabetes anyway, but it will compound that risk. Okay, so if someone has type 2 diabetes, then HRT, we see a lot of people, when their HRT is the right dose, that their symptoms, the HbA1c improves, their control improves, because they're fighting a bit of a problem if their hormones are against them as well, if it's increasing their glucose intolerance, and basically, if estrogen levels are at the right level, it helps the insulin act properly. Does that help?
Wonderful. I know there are loads more questions, but we won't get you to lunch if we do any more questions. So thank you ever so much. That was wonderful. So they've been waiting very patiently over on this side of the stage. So I have got Neil Taylor and Dr. Emily Watkins from FireFit, and they're going to talk about thermoregulation. I knew I'd have to write it down.
Okay, thank you, Lisa. I'm Neil Taylor. I'm an area manager in Lancashire Fire and Rescue Service, head of service delivery, and I'm also the chair of FireFit, which is one of the National Fire Chiefs Council's groups. I'll just ask Emily to briefly introduce yourself.